his vision, and because without his vision and the early awareness for the importance of a resource like this, we wouldn't be sitting here 8 years later with 1,200 patients' precious samples to share to the research community. And that's a pretty amazing thing. So the initial request Bob had made with help from MARF had been for $1 million. It was a one-time request, and the CDC thought the program was so important. They've continued to fund it at $1 million a year for now 8 years, going into its 8th year currently, but for 10 years. So little effort led to a pretty nice reward for the community. So I am a pathologist by training, and since I haven't spoken here before, but I'm getting a feel for the audience, can I ask just a quick question since it's after lunch and you're probably all ready to go to sleep on me? So first, how many people in the audience are patients? Raise your hands. So a couple, okay. How many are surgeons? All right. How many are pure researchers, not surgeons or patients? There's a lot of people who didn't put their hands up. Either you're asleep already or missing something. So what are some of the other groups that you represent? If you're not researchers or patients? Pardon? Oncologists. Oncologists. Okay, sorry. How many are oncologists? Yeah, I should have asked that. Oh, you get surgeons and oncologists to actually talk to one another? It's amazing. Okay. Pardon? Pulmonologists, too. Okay. All right. Pardon? Radiation oncology. Okay. All right, so we've got a good multidisciplinary group here. All right, well, as a pathologist, and now as for a long time cancer researcher, one of my always thoughts has been is to help cancer research go faster. You need to take and make sure patients' precious cancer samples make it into the hands of many researchers, and that's what NMVB does. NMVB right now is funded by the Center for Disease Control, the National Institute of Occupational Safety and Health, the only institute at the CDC, has funded us at the University of Pittsburgh as a coordinating site, and then Mount Sinai School of Medicine, our newest member of NMVB. They were not funded in the first 5 years. They were added in the 6th through 10th years of funding. University of Pennsylvania, which was an inaugural member, and New York University. And I won't list all of the surgeons and names of people that are involved in this for the sake of time to catch us up. But this is a multidisciplinary effort of pathologists, oncologists, surgeons, and researchers, and a bunch of really good technical staff to do this. So what's a virtual bank? Well, a virtual bank has a home on the internet, and this is our home on the internet. So if you want to find out about us, you can go to this site. All of our documents, our regulatory compliance, our manual of operations, our protocols, and actually a database that allows you to search the 1,200 cases that we've collected are all accessible from this portal. So it's virtual on the basis of anything you need to know about us already exists on the internet. So what we do is provide de-identified, so with all your clinical data, if you're a patient who signs up to donate your tissues to this resource, specimens and clinical data for research purposes. The database that we've constructed, and I'm chair of Department of Biomedical Informatics, so we do the computer science and database behind the scene to allow that to occur in a secure fashion. I'll hold it to you, there are very few places where you can go and query 1,200 patients worth of material and find out meaningful information about those patients. We collect 2 types of specimens, and I'll talk about those. One from patients who come and are consented and allow us to look through all of their records, get any other specimens, collect blood, and come back and actually interview them if we need with a consent form. We also have retrospective cases that patients who've had surgery before but haven't been consented at our institutions, and those 2 types of specimens are what we share to the research community. The hardest part of this is the clinical data, getting all the clinical data in a structured sense, and that's what we do very well. So if you wanted to apply for this resource, it's free. We do not charge any investigators, whether you're a commercial firm, whether you're a junior investigator, a senior investigator, for this resource. So it's completely free to the community. So in terms of just summary achievements, we've added Mount Sinai this year. We're collaborating with a SPORE program in an NCI grant that we're putting in for the third time that's going to be led with the University of Hawaii and Mayo Clinic. If that grant is funded, we will have 6 sites that are collecting tissue for this resource with the agreements to share them. There's a very useful tool called the tissue microarray, which I'll talk a little bit about more, that we now share out to the community with hundreds of patients' materials on a single slide with all the clinical data that flows with it. And when I did these slides, because we're in a very rapidly accruing session, we had 25 requests, we now have 30, and that doesn't include 3 requests that have gone to the Cancer Genome Atlas Project, the world's largest collection of cancer samples on patients, over 6,000, that also have genomic data for sharing to the research community. And we market this resource to the community, hence being here. So I won't go into the nerdy details, but there are a lot of moving parts to this at each of the sites, quality control mechanisms. We collaborate with the Meso Foundation for our advocacy arm. We have a group of scientists who are not funded by us who actually look at the requests that come in that tell us whether we should fulfill the request or not. And I have a manual of operations that describes this, so if you want to create a resource that's similar to this, you can either go to the website and download it, or you can write me and I'll email it to you directly. The informatics component of this is a little complicated. I won't get into it for this audience, but you got to have things firewalled where identifiers of patients live in a secure fashion, and what you share to the outside world is stripped of all of those HIPAA identifiers. So a bit of the magic that we do is the database that allows this to happen. So all of the identified data and all the specimens stay at the institution that actually have the patients and their materials. So if they're needed, they're still at the home, hospital, and laboratories. And the internet and our informatics tools connects everybody with sharing this data and the biospecimens, as well as requesting those specimens when a researcher needs them. So the types of specimens we collect everything: blood, serum, plasma, DNA from your blood samples. We take paraffin blocks, the thing that a pathologist used to look at that they create slides from. We take frozen material, and then we refine those so that when we supply the tissues to researchers, we give them just what they need and not more, so that we can ensure that the specimens, when a patient contributes it to the bank, it never is exhausted. My dad was an oil refinery worker, also asbestos exposed because he was a pipe fitter. Thank God he never got mesothelioma. And he taught me that, what an oil refinery does is magic. Well, we do this with tissue banking to get to just what you need of the highest quality, refined, to answer your research question, and to try to get it out of the raw materials, which you could consume quickly, so that they can be recycled. And our informatics system really does a very good job at inventory management so that no specimen is ever exhausted. I won't go through the detailed protocols, but a number of you are standing up clinical trials and doing work and have intentions of baking. We will share our protocols with you, our quality control mechanisms, and our documents through our manual of operations, which again is on the website. And we have very defined protocols both for blood and tissue processing collections, and standards and quality controls that are built into these. Data management is an important part of what we do, because if you don't keep the data up to date, it will not be helpful for investigators. So one of the active parts of this is to have somebody that actually manages and does quality control over all the clinical data that is collected. And essentially, whenever we fulfill a request for an investigator, we make sure that those patients' sample data is up to date, including all treatment information, vital status, progression status, and any other biomarkers or other data that we can collect along the way. So again, the number of requests that we've had, this slide reflects only one request that was denied. That was denied because it was such a comprehensive request. It was like they wanted to take half of the material in our bank and create a new bank. And happy to say that request has been refined and has been resubmitted to us, so maybe we'll even be removing that one that was rejected and closed. So again, without going through a lot of nerdy stuff, since I am an informatician computer scientist, we create a data model around the data so that it can be queried very deeply and comprehensively and be packaged in a way that we can share that data back out to the research community. And that's what our database model has constructed. We published our database model, and we've published our common data elements, and we encourage other mesothelioma researchers to use these very valuable pieces of infrastructure. All of the common data elements, the clinical data that's collected, is against other published standards for clinical data collection. And the model that we use for the database is, again, an open source model. And we actually have shared our database with a couple of other tissue banking collection models to date. So all the tools that have been created to this are freely shared into the research community. Our total accruals, although this is a little dated, are 1,100. We're actually approaching 1,200 currently. The total number of patient instances represented by those is 1,343, and the number of tissue samples is actually 1,015. If you look at the accruals, we opened in 2006. Most of the cases at that point were cases that already existed in our archives that we didn't have consent for, the retrospective cases. And we have steadily accrued the prospective cases, which have the fresh frozen tissue as well as the blood and serum samples. And these are our accruals through 2012. And again, we've had a really good year in 2013 and are approaching again 1,200 specimens with the addition of Mount Sinai to our collection frame. The types of samples are broken down here in terms of paraffin, the blocks that pathologists use, fresh frozen and bulk frozen material. And again, how many instances, patient instances of whole blood, serum, plasma, et cetera, that we have. We also collect a exposure questionnaire, an epidemiologic questionnaire on the patients, so we know how, whether or not they have documented asbestos exposure or not. Unfortunately, a good number of the cases that we have retrospectively in our database, we do not know the exposure history. We'd love to get funding to actually take adjacent lung tissue from all of these cases and do fiber typing and fiber documentation, asbestos fiber documentation, but we've not been able to get the funding to do that. Tissue microarrays are an important new tool. If you look at the top right here, this is what a tissue microarray looks like. It's a glass slide with little tissue spots on it. Each one of those tissue spots represents an individual patient. So if you were to put one marker on this slide, there are over 100 patients' data that you can get with one antibody stain on one slide for biomarker validation. A very valuable tool that in the previous tissue banks that I've set up turn out in general to be the most requested samples. It's kind of because you could do essentially an experiment on an individual slide with a biomarker. So all of our collection sites create TMAs. At Pitt we have one, at Penn and at NYU, and Mount Sinai is bringing one up. And the one thing, being the nerd that I am, our group has developed is a file system that tags all the clinical data to those patients. So we send you the slide, you can do the stain, but then we send you the database in a digital file that you can either download into Excel or put into a Microsoft Access or other database, where all the clinical data then on all those patients can exist. And if you want to do multiple biomarkers, you want to do 12 biomarkers, we'll give you 12 slides. You have 113 data elements on that, and you have a really pretty robust set of data to ask interesting questions on. So tissue microarrays are currently the second most frequently requested resource. They have only been up for a period of 3 years and are on track probably in the next year to pass fresh frozen tissue as the most requested specimen. Now the beautiful thing about this is one of those little spots represents about 1/300th of the area of a paraffin block. So I could do 300 of these and only exhaust one section from one paraffin block. This is where this kind of refining principle comes up. So these are very effective ways to share these resources over and over time and get lots of data out of very, very small pieces of tissue. Oops, went backwards. So our future plans, We are reapplying, unfortunately, for the Mesospore grant, and we want to expand this to Western locations. I'm also talking with Bob Cameron about figuring out a way to work on the West Coast with UCLA and Bob's practice and collaborators to bring a Western location into this network, because Penn, Philadelphia, and Pittsburgh are the 3 current collection sites, so we have no West Coast or Midwest collection sites. If the Mesospore gets funded, we'll have a Midwest site, because Mayo will get added, but we'd like to have better geographic distribution and support for the bank. We also are very actively getting ready for our renewal, even though it's over 2 years down the road, and what we want to become is a hub for not only sharing data and tissue samples, but sharing the genomic data that is produced with those samples. So right now, we have shared we're on track to share over 200 of the cases that we have in our archives with the NCI for the TCGA data, for the TCGA project, that's Cancer Genome Atlas project, and would like to become a provider for sharing that data to the research community with the very enhanced clinical data we have in NMVB. In TCGA, they collect about 20 data elements. In the NMVB, we collect 113. This will allow us to have deep sequencing and other forms of expression data on these cases and allow for the deep phenotyping and clinical information we have to be shared. And there have been some very exciting advances based on specimens that have come out of the bank in the last year that have helped provide some new insights into the genesis of mesothelioma and inherited gene defects that have been seen in a selected number of families with familial mesothelioma that really have come out of the work in this resource. So other partners that we're trying to work with include the Pacific Meso Foundation here with Bob, as I mentioned, the National Center for Vermiculite and Asbestos-Related Cancers that Mike Harbut has stood up at in Michigan, and the Insulators Union Tissue Bank, which has sponsored a bank at Mount Sinai. Andy Todd, an epidemiologist, heads that bank up, with goals to share resources and share tools with these other centers. We're a little bit concerned about our funding future, because everybody should be, with the craziness in Washington and a lack of a federal budget for going on 6 years. That's never happened in the history of the United States, to not pass a federal budget in 6 years. Thank you. Thank you to Congress and our visionary leadership at the head of the White House. So this makes it for an uncertain time. If the CDC pulls our funding, this is going to hurt. So we're obviously hopeful that that won't happen, but to be honest, this would be a tragedy, because this is really used by the community quite a bit. So I want to thank all the partners, particularly Steve Abelda and Mike Feldman at Penn, Raja Flores at Mount Sinai, Jim Pinkpank, Arjun Pendathor, and Jim Lukatich at Pittsburgh, and Harvey Pass and Jonathan Melamed at NYU, because without them, the surgeons, the pathologists working together, this is not happening. So we market our efforts at most major meetings. We've published quite a bit. All of our tools are open source and in the open access literature. So if you need anything from us, let us know. And for the couple of patients that are in the audience, one of the common things I get is, well, how do I get my samples to your bank? Unfortunately, unless you're in a geographic region where we have a collection site, that's hard to do. On the other hand, the Insulators Union has been talking with us about what they're doing with Andy Todd to try to put kits together, so that if you wanted to sign up for this resource down the road, a kit could be sent to your surgeon and your treatment center with the appropriate unfortunate regulatory and material transfer agreements and all the paperwork we'll be happy to take on to try to get as many patient samples into the bank as possible. And then we could truly be virtual, not just counting on our current collection sites. So we're aiming in that direction. So these are a list of publications. If you want any of them, email me. I'm easy to find on the internet. I give kudos to all the docs, but these are the real workers at all of our sites. the technical people, the regulatory people, the clinical coordinators, the nurses, the informatics folks that do the hard work. So I wanted to give them kudos as well. So thank you. And I appreciate the opportunity, and I've caught you back up on schedule.